Welcome to ATCM Emergency Medicine channel. Today we are going to discuss about the ocular trauma. We briefly discuss about the anatomy of the eye. Cornea is a transparent layer. It's the anterior border of the space of the anterior chamber continuous with sclera, and interior the eye can be divided into anterior segment and posterior segment by the lens. Anterior segment includes cornea, sclera, conjunctiva, iris and lens, and cornea and iris present in the anterior chamber, and behind the iris is the posterior chamber, which both includes aqueous humor. And in the posterior segment contains lens and retina with vitreous humor, which is a clear jelly like substance. And optic nerve is in the back of the eye, which travels through the muscle cone through the orbit and then into the brain. And in the globe, extraocular muscles attachment to the sclera, and the sclera and muscles are covered by the epithelium, which is known as conjunctiva, which extends from the cornea sclera junction over the sclera and then turns to cover the inside of the eyelid. And extraocular muscles join together to make a cone, and that is covered by the Tenon's capsule. And it is a minimally distensible fascia, so that it limits the ability of the muscles to expand. So if there is any hemorrhage in this area, that will lead to compartmental syndrome. And the globe and muscle cone complex sits in the orbit, and orbit is a pear-shaped cavity by bone that separate the orbital compartment from the sinus and the brain tissue. And the eyelids have a tendinous attachment, that is canthal tendons, which medially and temporally on the bony orbit, which keep the globe from moving forward. And it creates another space with limited expansion. This is a brief anatomy of the eye. And if a patient comes with an ocular trauma, we should do an assessment. That assessment mainly focused on history, physical examination, and we have to inquire about the pre-injury comorbidities and vision history. In case of history, we want to know about the time and mechanism of injury, and also complete review of the systems, and also about the patient's past medical history. In physical examination, we mainly focus on vision, pupil, intraocular pressure, which includes the basic health of the eye and also the anterior and posterior segment of eye. In case of vision, we hold a near vision test card and at appropriate distance, and we can record the vision in each eye. And always note that whether the patient use any glasses or contact lenses before for any short or long vision. And if the patient has any refractive error present, ask the patient to look through a pinhole so that we can minimize the refractive error and check the vision. So for that, we can either use the pinhole occluder, otherwise we can take a piece of paper or cardboard and use a ballpoint pen or paper clip to make a hole of 0.2 mm in the center. And next we can assess the pupil. Pupil usually, we have to first remove the contact lens if the patient is using any, and after that we have to check the pupil. Usually it is equal, round and reactive without any afferent pupillary defect. If the pupil is sluggish and poorly reactive pupil, there is a possibility for brain injury, either stroke or any herniation. If the pupil is enlarged following a blunt trauma, there is chance for pupillary sphincter tear or any history of past surgery or other ocular diseases. When abnormal pupillary exam result from an ocular cause, pupil retains some reactivity to light even though it is different size. If there is no past ocular history, evaluate for any intracranial pathology. And also we can do the swinging flashlight test for the optic nerve dysfunction. If there is afferent pupillary defect, if any defect in the swinging flashlight test, we have to consult the ophthalmologist. And next we can check the IOP, intraocular pressure, using a handheld tonometry device, which is tone pen. First we have to open the eyelid and careful not to push the globe. And if you push the globe, there will be false elevation in the IOP. And make sure the finger should rest on the bony orbit, not on the globe. And normal IOP is around 8 to 21 mm of Hg. Always do 2 to 3 measurements and take the mean of the measurement. And readings can vary in case if the patient is in any mechanical ventilation, or if there is any Valsalva maneuver or accidental pressure on the globe. So that we have to anesthetize the eye with topical anesthetic ophthalmic drops like proparacaine. And if the patient is not fully sedated, otherwise patient will blink excessively or squeeze the eyelids when tip of the instrument touches the eye. Other method is that we can gently press with our 2 index fingers on each side of the eye with eyelid closed. If you are not sure about the normal pressure of the normal pressure feel of the eye, we can press our own eye or the unaffected eye and we can get the feel of the normal pressure. If you're suspecting any open globe injury, do not check the eye pressure at that point. It might make more intraocular contents from the eye. And in such cases, check visual acuity and conduct the visual inspection only. In case of anterior examination, we have to check the periorbita.
So generally, when you are examining eye, we need to examine for the what all things we need to examine for the visual acuity and the field of vision and also the extraocular movement.
Yes.
And when you so we will have to first we will look the visual acuity. So what all things patient can see, this thing should be checked, and the field. How will you check the field of vision?
We can move the fingers and check the field.
No, we'll have to occlude. If we are sitting opposite the patient, if we are occluding our left side, patient should occlude the right side. And then we'll have to check the field of vision. That should be checked. So visual acuity is the vision as such, then field of vision and also the extraocular movement should be checked. Then when we are coming to the eye, then first we'll have to look for the, not directly to the pupil or cornea, first we'll have to look for the lids, the eyelashes and everything, and then only we'll have to enter into the eye.
In anterior examination, we have to check for the periorbita, any ecchymosis, lacerations around the eye, and evaluate also for the proptosis like forward extent of the globe by eyelids either open or closed. If one eye farther forward than the other, then we have to do the radiographic evaluation by using the axial cut of the CT head scan by measuring the from lateral wall of the orbit to the nose on each side and measure how much of the globe protruding beyond this imaginary line. If there is any resistance to the retropulsion, indicate that there is possibility of increased pressure behind the eye, which will help us to suspect any retrobulbar hemorrhage. If the globe pushes against the eyelids, creating such pressure that the eyelid is taut, then cannot be pulled away from the globe. Also, we can suspect retrobulbar hemorrhage.
So, if there is any retrobulbar hematoma, what all symptoms will be there for the patient?
There will be decreased vision will be there.
Decreased vision will be there, and we will be seeing proptosis also. And when we are trying to press, we will not be getting that
difficulty to press the globe.
Difficulty in retropulsion will be there.
And so the eyelid will be taut.
Okay. What should be done in that case if we are clinically suspecting a retrobulbar hematoma?
We can.
So that means there is something behind the eyes which is, there is a hematoma that is pushing the eyes. So that is bad for the eyes. So what we'll give an emergency ophthalmology consultation and we'll have to do a lateral canthotomy and a cantholalysis should be done. Okay.
While evaluating the periorbita, inspect any lacerations and that are not full thickness, we have to eliminate the possibility of concealed foreign body also. And in extraocular muscles testing, ask them to follow your finger up, down and side to side. And if there is any restricted ocular movements, there is possibility for high pressure inside the orbit or there is any orbital fracture or muscle or nerve injury. And also look for lids, lashes and lacrimal sac. Eyelids for lacerations, full and partial thickness lacerations. And if there is full thickness lid laceration, that requires surgical repair. That repair should be within 72 hours of injury. And if any damage to the lacrimal duct system, repair it before the onset of edema. And in conjunctiva, sclera and cornea, conjunctival hemorrhage and extent, if it is more extensive, more likely globe has sustained injuries. And also check for lacerations or aberrations of conjunctiva, sclera and cornea. And we can also do fluorescent dye test. For that, we have to anesthetize the eye with topical drops and using moistened fluorescent strip, place few drops of fluorescent in the eye and patient need to blink to fully distribute the eye and shine a blue light, either the Woods lamp or ophthalmoscope on the eye, and dye will fluorescence in the green spectrum and highlight the area of epithelium that has been disrupted. And if there is any minor aberrations in the cornea and conjunctiva, only ophthalmic ointment is required. But in case of lacerations in the cornea and sclera, if it is full thickness, we have to suspect the open globe injury and immediate ophthalmology consultation should be done. And if there is any contact lens, we have to remove that. If there is extended period, there will be more risk of infections and corneal ulcer. And we also check the iris. If pupil is round and reactive but slightly larger than the unaffected, likely there is a possibility of pupillary sphincter tear. That is more common with blunt trauma. And with the smaller globe injuries, globe remain formed, but pupil is irregular with peaked appearance. Look for any iris plugging the hole in the globe and poking out of the sclera or cornea in direction in which the pupil is pointing. And there is chance for full thickness laceration also. In checking in the anterior chamber, it should be relatively deep, that is 45-degree angle between the iris plane and curve of cornea. So, and the aqueous humor is usually clear. If the iris is very much close to the cornea, then that reveals the possibility of anterior chamber is shallow and aqueous humor may be leaking out due to open globe. So we have to look for any clouding of the fluid, RBC. It is known as hyphema, either the dispersed or layered. Dispersed means RBC is floating in the aqueous humor, making the patient vision and your view into the eyes very much hazy. In case of layered, the blood will be on the top of the iris, layered with blood inferiorly. And if gravity shifted the blood cells down, in that case, IOP will be high and there will be possibility of significant trauma to the eye. And in case of lens, capsule is violated and lens turns into white. Lens has swelling with time. So significant primary inflammation will be there and that will lead to increase in the IOP also. In posterior examination, it will be difficult to examine. So if the pupil is small or if the patient is on any pain medication, so at that time we can only check for the reddish orange reflection of the light from the retina. If the pupil is larger, we can use ophthalmoscope to visualize the posterior retina or the optic nerve. If we cannot view the back of, then we cannot exclude the possibility of the vitreous hemorrhage or retinal detachment. So we have to give a ophthalmology consultation to look for the posterior side. And there is also possibility for orbit fractures. In case of orbit fractures, there will be bleeding into the muscle cone or around it. That will lead to compartment syndrome and obstruct the blood supply to the optic nerve and globe. In that case, we can see in the we earlier discussed about that the signs of retrobulbar hemorrhage with compartment syndrome. There will be decreased vision and elevated eye pressure and asymmetrical proptosis and resistance to retropulsion and tight eyelid against the globe, rock hard eye. And in this case, compartment syndrome can be understood by the clinical examination and CT scan will reveal the hemorrhage. So there will be chance for vision loss if there is 1.5 hours of impaired blood supply. So in that case, we do canthotomy or cantholysis, increase the size of the orbital compartment, just like fasciotomy. And we do not delay the procedure for obtaining a CT scan. And in case of orbital fracture, there will be entrapment of the extraocular muscles within the fracture site. So we have to repair it within 48 hours of onset to prevent the muscle ischemia and permanent damage. In case of larger fractures, not usually cause impingement syndrome and ischemia. Entrapment usually seen in the smaller fractures and that is more common in children. And in case of chemical burns, it is a true ocular emergency.
Okay,
For that,
so,
we can
we'll just pause here. So, suppose a patient is coming to ER with a major injury to the eye. So, what all will be the symptoms of the patient? Any trauma, let it be any trauma. What all will be the symptoms?
pain.
Pain will be there.
Decreased vision will be
Pain, irritation, lacrimation, photophobia might be there, and because of the blepharospasm, patient might not be even able to open the eyes, or if that itself is not there, patient might be having severe lid edema and patient might not be able to open. Okay, that is in case of a severe injury. What if a patient comes to ER with a foreign body, like patient was traveling in a bike, a foreign body, something got into the eye. So what will we do in ER? What can be done?
saline irrigation can be.
Okay, how will you give a saline wash? Saline wash to get rid of the foreign body. How will you give it?
10 ml syringe.
Take the needle and sharp and when we tip on the syringe, then forcefully push the
From one side to
the eye. So
Where into the eye? Is it in the cornea or the sclera?
medial.
Scleral area. Don't directly push anything to the cornea, but to the scleral region, to the conjunctiva and sclera. That white portion we need to press the syringe. Okay. So that is the eye wash to remove the foreign body. Okay, so that is one step which can be done. What if the patient is having severe blepharospasm and we are not able to open the eye and we are seeing something onto the corneal region? What will you do? Because all the patients might not be coming, might not be in a position to open the eye. So we can give some cycloplegics. What can be given? We can give. Have you heard about homatropin and all? Homatropin. So such agents, atropine will have an action for at least 7 days. If we are giving atropine eye drops and all. If we are giving homatropin, we are giving 5% homatropin as drops. Then it will help to prevent some blepharospasm and some pain also will come down. The patient is having severe eye pain and if you are suspecting anything to the cornea, we can give drops of homatropin or we can give other agents like cyclopentolate 1% can be given as an eye drop. That is to prevent the spasm and this closing tendency. That is for the spasm and this thing. And for the pain, what can be given? Pain, we can give local anesthetic. What was the thing you told? Proparacaine can be given. 0.5% of the proparacaine drops, eye drops can be given so that the pain also will come down. So first thing that can be done is we can give eye wash. If we are having severe spasm related issues, we can give any antispasmodic agents, and for the pain we can give the local anesthetic drops. And if anything is involving the cornea and if it is only mild, like a very superficial thing, cornea will regenerate within 24 to 48 hours. So it will spontaneously regenerate and resolve by itself. But if it is major, we will have to ask for an ophthalmic consultation. Okay, so if we are discharging from the ED, what can be given before discharge if it is an injury to the eye? Antibiotic should be. What antibiotic will you give?
Fluoroquinolones.
Fluoroquinolones can be given, or like ciprofloxacin, any fluoroquinolones can be given. Ciproflox eye drops can be given, or you can give eye drops of any other eye drops can be given. What did you say? Gentamicin eye drops can be given. Okay. So when you are giving that also, we are allowed to give every 4th hourly for at least 3 days. We will have to give so that will heal and that will not cause further infections. That is the one which we are giving. That is only for a dischargeable patient, that from ER side. So if you are suspecting any penetrating corneal injuries only, we will be planning to do the Siddle's test. What is Siddle's test?
Anesthetize. If there is any small leaks, we have to first anesthetize and we place the wet fluorescein into the eye and not ask the patient not to blink. If there is any small leaks, anything, it will get wet. If the fluorescein is not wet, it produces a bright orange color. If it is wet, it will turn into light orange in the blue light.
Okay. So usually this 10% of fluorescent dye we'll get. Either we'll get as strips or we'll get as drops. That is green in color. We will be keeping it either we will be using the cobalt light in slit lamp. We will be examining, and if we are seeing anything penetrating and if we are seeing the anterior chamber, the dye is entering inside the anterior chamber, it will be looking like an yellow color. So the green dye, when we check in the cobalt blue light, we will be seeing yellow color in the anterior chamber. So if we are seeing like that, that means that there is something, a penetrating injury is happening. That should be. So that is the one. Okay.
In case of chemical burns, it is a true ocular emergency. For that, we have to do the copious irrigation.
And the antibiotic can be chloramphenicol also can be given. 0.5% can be given.
We have to do the copious irrigation of the affected eye. A liter of NS or RL, we can connect into a Morgan lens, which place the lens in the eye. And
so what do you mean by chemical injury to the eye?
Any powder or acid or alkali.
Acid or alkali. So if it is an alkali, what injury will happen to the eye? There is acid and alkali. you can just remember as alkali has L. It is liquefactive necrosis. Acid, coagulate. Acid has C. So coagulative necrosis can happen to the eye. So what all are the alkalis which will cause problems to the eyes? Like patient is coming, I was cleaning the oven, I got exposed to these things. So when will you consider it as acid? What is an acid? Was it, or which all are the alkalis on day-to-day practice? Detergents, any detergents, alkalis, any cement, lime, any ammonia content things can be alkalis, any oven cleaning agents like that, any bleaches, these can be alkalis. Acid, any floor cleaning agents, toilet cleaning agents, these are acids. Okay, so that history should be taken, what that is, and what will you do if the patient is coming with that exposure to eye?
We have to do the copious irrigation with, after placing the Morgan lens, we can continuously infuse the.
What is Morgan lens?
It's a lens shaped thing with a connection tube. With that we can give continuous irrigation to it from one side of the eye. We have to tilt the patient's head to one side so that it will continuously irrigate from one side to the other, and we have, otherwise we can.
So how much, what fluid will you take?
NS or RL.
Okay, normal. So how much NS is required to irrigate?
1 liter.
Okay, 1 liter of normal saline you are taking, and how much time will you irrigate? 30 minutes. So if a patient is coming with an acid or alkali exposure to eye, our aim is to make the pH of the eye normal. So what is the normal targeted pH which is required? Between 7 to 7.5. 7 to 7.5 is the targeted pH required. So what we should do is we can use a Morgan's lens and we can irrigate the eye. At least 1 to 2 liter of fluid NS is required and should be irrigated to 20 to 30 minutes. And how often should you check the pH?
After that we have to wait for 5 minutes, then we will recheck till the pH is neutral.
So if the pH is not neutral, then we will have to irrigate again. And another thing is that during this procedure also, if the patient is having severe pain, we will have to give topical analgesic should be given. So if patient is having severe pain, during the irrigation every 5 minutes, we will have to give the analgesics. Okay.
And we have to discharge, we can discharge medications, add antibiotic ointment with pain medications.
What are the complications in case of an acid or alkali exposure? Strictures will be there. Okay, so it is actually a necrosis, either a coagulative necrosis or liquefactive necrosis is there. So there can be strictures which can lead to any glaucoma. Then if it is involving the lens, it will cause refractory errors, not that. Long-term cataract can happen. So these complications are there. So as early as possible, we need to neutralize the chemical agent. Okay.
Next we are going to discuss about the open globe injuries, eye injuries with full thickness penetration through sclera or cornea. The signs will be the peak pupil and shallow anterior chamber, and there will be corneal or scleral lacerations and abnormal pigmented tissue pushing through the sclera or cornea, and presence of floating RBCs or WBCs while we check through the slit lamp examination. And in that case also we can do the Seidel test to locate the small leaks, and in that case the immediate intervention is required in case of hemodynamically stable patients. We can transfer, if we are transferring the patient, we have to cover the affected eye with rigid shield. If the foreign body is sticking out, we can cut a foam or paper cup to accommodate the foreign body, but we have never placed the pressure dressing or gauze or soft material under the rigid shield. The pressure may force the contents out of the eye, or gauze or soft eye pad sticks to the extended iris and ocular content and pulled out the eye when removing the pad. And we also have to provide IV antibiotics. Fluoroquinolones penetrate vitreous with therapeutic concentration, and when given, we can also give IV gatifloxacin or levofloxacin. If unavailable, we can give any IV broad spectrum antibiotics, and also tetanus immunization. And we should tell the patient to minimize the eye movement. Extraocular movements further extrude the intraocular content. So moving good eye also will lead to the injured eye to move because of the brain coordination. And we have to treat the pain, nausea and coughing, and to reduce those activities. And if the patient is intubated,
That is to prevent
increased pressure and
increased intraocular pressure.
And we have also minimized the manipulation of the eye and not perform any examination beyond the visual acuity and observation. And also order for CT scan with fine cuts if we are planning to do any procedure in our hospital. When generally we use the cuts with 1 mm or less, and IV contrast is not required. When you suspect any open globe injuries, we should call ophthalmologist as early as possible for immediate examination and for the definitive diagnosis and treatment.